Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
All right, welcome to the Pod of Inquiry this week. You're going to love this week's guest. My guest is Dr. Edgardo Rodriguez-Collazo. Edgardo is a lower extremity peripheral nerve specialist who focuses on adult and pediatric limb length deformity and corrections. He is a board member and fellow of the Association of Extremity Nerve Surgeons, and he is a founder and advisory board member of the American Microsurgical Orthoplastic Society. I have known Dr. Rodriguez-Collazo for more than 20 years and can say without any hesitation that he is one of the most gifted and true leaders in lower extremity peripheral nerve surgery. He has taught me many things as well as other surgeons throughout the world. Edgardo has probably spent more time in the cadaveric surgical lab than anyone I have known. He is a lifelong learner, and even more, he's a great teacher. Please enjoy this conversation I have with him discussing nuances of peripheral nerve surgery that he has both developed and refined. All right. Good morning, Dr. Edgardo Rodriguez, a friend that has collaborated with me for many, many years in the profession. And I guess that means we're old, but thanks for taking the time to jump on today. And let's have some fun. You've been producing a lot of great literature recently, so we'll talk about some of that. But before we get started and dive into that, why don't you tell everybody, maybe there's a few people that don't know who you are, what you've done up there, and maybe talk about CLES a little bit, because I think you've really established some great educational platforms.
Fantastic. Well, listen, Steve, thank you for having me. I think it's awesome. It's always great to be with you and do something together. I mean, we have been really collaborating since 2000, believe it or not. So it's been a long process and journey for both of us. So I'm still practicing in Chicago. I'm part of the Department of Surgery at Amira Health. I should say now is Ascension Health. And the emphasis of the practice has been all this time basically complex reconstructions and microsurgical limb procedures. So in that process, we have a fellowship program on a yearly basis that we have been able to have some surgeons now that are more involved in academic events, especially on peripheral nerve, and also in plastic reconstruction of the limb. What else can I say? We had the symposium that is a yearly event. It's the Chicago Lower Extremity Surgical Symposium. We have been, that event is the 17th year that we have that in place. This year was in Dallas. It's always in October, the third week of October. And we train 80 surgeons, 2 days on cadaveric participation, and then we had a pre-course on controversies of limb lengthening and reconstruction at Texas Scottish Rite. Next year, it's going to be again in October, the third week, but it's going to be 3 days in the lab straight, and 1 day that is going to be at Texas Scottish Rite. So it perhaps will be the only meeting that can offer three cadaveric days in a row.
Wow. That's fantastic. Now, is this the first year that you've moved it from Chicago down to Texas?
We did it. Second? We did it after the pandemic, and the reason why, because we just run out of budget. They're not really being able to put the symposium out. It's a non-for-profit. All the faculty, including myself, we just provide the preparation of the event, lectures and skills for free. So it's definitely meeting that surgeon with an emphasis in limb reconstruction and plastics. But what I had to say is that the integration of the specialties is providing a fantastic educational event. It's just providing more case scenarios. It's providing diversity of the cases, challenges, a synergistic approach of specialties teaching each other. So it's been a very, very good in that sense. Whatever funds we have after we pay all expenses, we donate for medical missions in Latin America, in which we basically target, in those cases, pediatric deformities.
Right.
Yeah.
Well, you've been doing a lot of great stuff, and you've got 3 papers that you just sent to me. And I when you asked me if I'd seen them, I said no, but I actually did. But let's talk about end-to-side nerve transfer a little bit for drop foot, because I think that is something that's pretty, top of mind. And a lot of the people, we just had our nerve meeting last weekend, which you so kindly presented. And there was a lot of talk about end-to-side transfer, and sometimes they call it the hot wire technique. Mm-hmm. So, and this study, you had 17, I believe it was 17 cases, and it was pretty impressive, actually.
Yeah, 17 cases, but I tracked those for over 4 years. I'm still performing those procedures, and patients, they just travel to Chicago for that. There's not that many surgeons that are performing that procedure in particular. But I basically, when I developed that procedure, it was basically to extrapolate to procedures that they were performed at that time for the same pathology, and taking some of the data from brachial plexus injuries and upper extremity paralysis. And basically, in the process of developing that technique, I think I closely, the last time that I put my thoughts together, it was over 600 limbs that I dissected before I started just really performing that procedure and really getting to the point that I was teaching the procedure. I taught the procedure for quite some time, I mean, you and others, but getting the final publication in the Journal of Reconstructive Microsurgery, I think was a great accomplishment.
I think so.
Yeah.
Now, what did you we always morph and evolve as we have more clinical experience, more cadaveric dissection experience. Has there been any evolution in what you've been doing as far as this particular procedure is concerned?
Well, you know what? So the way that I describe it was basically end-to-side transfer of fascicles from the superficial peroneal nerve directly to the injured deep peroneal nerve at the proximal one-third of the tibia, just in the area of the anterior septum of the fibula, or closer to the intermuscular septum between the EDL and the tibialis anterior. I still perform that procedure identically the way that it has been described. The modifications of paralysis of the lower extremity, in which involve the superficial peroneal nerve and the deep peroneal nerve combine more or less right before the division of those two nerves out of the common peroneal nerve, then what I have been able to in some way advocate in conjunction with Dr. Ashad Khan from Texas has been, instead of isolating for specific nerve in the gastroc and the soleus, just basically elevating a portion of the muscle with the motor unit within, and then placing those over the common peroneal nerve area or the superficial peroneal nerve. So then at that point will be a distribution of the tibial nerve, not from the common.
So let me get this straight so the audience can and know what you're talking about, what we're talking about. When you're doing an end to side transfer, you're taking a nerve, let's call it the donor.
That goes to the peroneus longus lateral compartment, let's put it that way. So I harvest from the lateral compartment.
Okay, so you harvest, which would be a branch off the superficial perineal in the lateral compartment. So you're harvesting a branch there, and you're basically transferring it end to side in most likely the deep perineal nerve distal to the area of injury. Is that correct?
Exactly, correct.
Okay.
And that area gets identified with intraoperative nerve stimulation. Okay. So the area that you stimulate and get a positive response, that's the area where the recipient site or recipient nerve segment. And but prior to surgery, we need to stimulate those muscles to see if they're viable. And that will require some needling of the entire proximal 1/3 to the middle 1/3 of the tibia in the anterior compartment of the leg.
So you're focusing primarily then on tibialis anterior, I would assume.
Yeah, there's some branches of the that are going to the extensor digitorum longus.
Right.
I mean, the problem is that in the upper extremity, compared to the lower extremity nerves are not really so well mapping the distribution like in the upper extremity. So there's a lot of same as in plastic crossover perforator flow. So it's basically in the lower extremity. You'd be surprised that there's a lot of the same similarity. It's not isolated nerve to a specific area, but a conjunction on a combined fascicles.
Now, I've seen some different things on the actual nuances of the end to side anastomosis. Are you just basically opening up the epineurium and plugging it into the epineurium? How are you handling that particular aspect of the procedure?
So I initially advocate for an epidural window to it, especially if you have thickening of the epineurium. So you definitely, I think that it's mandatory if there's some thickening of the recipient segment, there's not a non-traumatized epineurium. In other words, there's no thickness around that segment. So I still believe that that's really the best way. But back again, if the recipient nerve area, the epineurium is in good quality, let's put it that way, and by me placing the nerve and stimulating the nerve, I get the response, it's not necessary.
Okay, so you're opening up the epineurium, you're taking your donor nerve, you're plugging it in there, 9/0 suture. We're breaking up.
Section with microsurgical loops, and then I use the microscope in those cases.
We lost you there a little bit. The internet connection went a little bit funny. So tell me how are you anastomosing?
I do the entire dissection with loop magnification, but when it's time for the end to side transfer, I use either 10/0 or 11/0.
Okay.
So then in those cases, then I prefer to use a microscope.
Have you seen anybody using a connector that they kind of split and it acts as a little bit of a conduit?
So interesting. If you do the epineurial window, okay, those axons, I think that they're doing their function, at least in my cases. I don't have no experience of using a conduit and then that conduit to the epineurium of the recipient.
Right.
No, I have not used that one, that technique.
So then you're able to stimulate that and actually get a signal into that right at the time in the operation itself.
You got it. So you want to basically have a low amplitude. So basically you, at that point will be like a 0.5 milliamps.
Okay.
Then on the amplitude and impulse, no more than 100. And if I get a response in which I see extension of the foot and in of the toes also, if it's stimulating the EDL. That means that patient for sure, I can talk to them after surgery and I'll tell them that they're going to have a 3 out of 5 in muscles.
Okay.
Because in reality, you start seeing people with weaknesses is 3 out of 5, they can clear the ground and they can have a much better function. And sometimes they don't need an AFO with 3 out of 5. So it's basically 0, 1, and 2 muscle weakness when I believe that these patients, they're having a lot of dysfunction.
Now, in your paper, you show some pretty dramatic improvements in muscle strength. And
I know.
You took, there were a couple you took from like 1 to 5.
That's right.
Yeah.
So it's extremely powerful. On a weekly basis, I get patients sending me videos because I tell them expectations is everything. I think it's going to be very good. It's going to help you out, change your quality of life. But I tell them, let's not expect a miracle here either. Let's see how it goes. And I tell them 3 months, 6 months, 9 months, and a year as benchmarks.
Okay.
So we cannot really, determine right away the outcome and the success on 3 or 6 months. I really like a year.
What are you doing post-operatively for them? How are you managing them post-op? Because when you put an 11-0 suture, you want to probably not have them doing too much.
No, perfectly. Yeah. So basically 1 week, I put them in an ACL knee brace in which they cannot extend or flex the knee. The procedure is done without any type of tourniquet or ischemia, just because I really want to be able to control bleeding to the best of my abilities. And there's a lot of septal perforators in that area that you need to cauterize and control very well. And I'm always in the OR asking the anesthesiologist, what is the blood pressure? Because you may have good hemostasis, but the minute that the anesthesia returns the patient to the normal pre-surgery blood pressure, then you may have a blood pool in that area, which will be catastrophic for the patient. So I do believe in doing these patients with the closest blood pressure to the pre-op time and under no tourniquet.
Yeah, we found that we're using fewer and fewer tourniquets now. There are a couple of procedures that we'll use them routinely on, but we always put a tourniquet on in case we need it, but rarely do we. Yeah, rarely do we.
So basically, recovery is basically 3 weeks in which I like to use staples in that area. So if there's any bleeding, it can come out.
Right.
I like to always put a drain in that area that usually I remove when there's less than 14 cc's in 24 hours. And I put them in a knee brace for 10 days.
Gotcha. Now, in your data that you compiled in that study, some of those folks had some pretty long durations of, let's call it lack of function. And you know that the motor end plates tend to drop out. There's an arbitrary timeline of 13 months. I don't know where that came from because I've seen people that have been, suffering from drop foot, very like 0 out of 5 motor strength for 5 years, and you do something and all of a sudden it comes back. So I don't know how true that is, but what was your experience? Shorter duration, better outcome?
I think that for the type 1 nerve injury, the neuropraxia, the sooner the better, no doubt about it.
Right.
I think that the sooner you can do a neurolysis of that nerve, the better they're going to do. And I think that's everybody can agree on that. Wait a second. I'm not sure everybody does agree on that because we have people come in all the time and they say, well, I got this drop foot after my knee surgery or after a hip surgery. And they just said, well, just wait for 6 months, 12 months. And, I mean, that's I think a gross misunderstanding of the process. So I think that the key is constantly monitoring this patient and constantly order nerve conduction studies. So if a patient comes to the practice and it has a traumatic injury, traction of the knee while they're having a total knee arthroplasty, whatever is the reason, but there's not a direct traumatic injury to the sense of possible type 2 or type 3 nerve injury, just basically type 1. If within a month from me seeing that patient, I don't see that they're obtaining not even a point on muscle strength, I order another nerve conduction study.
Okay.
I tell them, if we don't see that you are in 3 months and it's a nerve conduction on a monthly basis, you're not obtaining 50%, you're gonna end up then later with the transfer, most likely, or a tendon transfer. And
Right.
And I think that that's really the take-home message, that these patients, you had to monitor them a little bit more closely. But you'll be surprised. Sometimes you may see patients with the absence of dorsiflexion. You put them in a low dose of steroid, some Lyrica, and immobilize a little for a week or 2 weeks, and they gain a point on muscle strength. So, but then you have the patients like what you just described, that they have prolonged paralysis of the extremity, and you do the neurolysis and they respond very well. So I think it's all about each individual patient and the amount of muscle denervation that have occurred.
Yeah, I don't know if you know much about the Phoenix sign, but we've been talking about that quite a bit for the last 5 years. And it's pretty incredible how, you think this patient has nothing, and then all of a sudden you put a little vasodilation agent, whether it's lidocaine or papaverine, and all of a sudden now they got 4 out of 5 or 5 out of 5 dorsiflexion.
Yeah.
Super predictive, so you can kind of tell them, hey, this is what to expect. But yeah. I think it's,
I think it's fantastic what you put together on that sense, because that the lidocaine is going to relax the muscle. So basically, by relaxing the muscle, the nerve that is going underneath, okay, it's going to have less compression. So
now, I don't think it's a muscular phenomena, Edgardo, because we're only using 0.2 of a cc, and so you wouldn't get that much skeletal muscle relaxation from papaverine. So I think it's strictly vasodilation.
Because so you basically on the mesoneurium, no?
No, you broke up a little.
Increasing the blood.
Say that again. You broke up.
You increasing the blood flow at the intraneural level or the mesoneurium.
Right.
Perhaps,
Right. And so the other thing that we've seen that's very interesting with this, and we just finished a prospective double-blinded study comparing lidocaine with papaverine, and we found equivalent results in both groups. So we've pretty much taken the theory that there's some phenomena associated with the anesthetic part of the local anesthetic, and it really, I think, is a vasodilatory mechanism, and I think the papaverine helps support that thesis. But I know Nuremberg published his lidocaine. I think he called it the LIT test, lidocaine infiltration technique, or something like that, where he was putting about, I think, 3 cc's in the muscle itself. And our findings didn't support muscular relaxation, because if you think about it, they have more motor strength after. So if you made a muscle flaccid, how would that necessarily work?
Yeah, you have a great point. And I think that perhaps it may be that the infiltration in the proximal 1/3, but the maximum muscle strength is not really at the proximal 1/3. It's really more distal. So the muscle at the origin and then the insertion, it's not where they have the maximum strength. It's right in the center, in the belly. And the belly of the tibialis anterior is not really at proximal 1/3. It's a little bit more distal to the proximal 1/3, or beginning of the middle 1/3. So, but I think that it's not clear yet. But I think the take-home message, like you said, is that if you have the Phoenix sign, and it's a great way in the clinic to know that possibly a neurolysis has a great
it's got a chance.
That's right, exactly.
Right.
And like you so well put together in that article, it's a great way to know, really, for the patient's sake also, they can have their hope. And
exactly.
And I think hope is great to see that on these type of patients.
And now a message from our sponsor. Well, folks, if you're over 40 and you're not using a supplement to augment nitric oxide production, you should really rethink that. This molecule is absolutely imperative to health, not to mention the cardioprotection. Nitric oxide is a physiological molecule that does so many things for your health. I never miss a day of nitric oxide supplementation. That's how important it is. Long overdue, there is now a nitric oxide replenishment formula without the fear of oxalates. Approved Medical Solutions does not use beets, spinach, or arginine. Approved Medical Solutions is proud to offer our audience their oxalate-free nitric oxide formula. If you are not a healthcare provider, you can still get started by going to approvedmedicalsolutions.com and use the code SBarrett at checkout, and you will receive a 10% medical discount savings. For licensed practitioners, just go to approvedmedicalsolutions.com and register. They have unique bundles for all of the full-fledged spelunkers of the Pod of Inquiry. Use Pod of Inquiry at checkout after registration, and I am certain you will be pleased not only for yourself, but for all of your patients. Here's a little secret. If you order their testing strips and test every patient for a few clinic days, you will see that nearly every one of them will be deficient. When they see this result, they will want you to start them on it immediately. Now, thanks to Approved Medical Solutions, you can give them the best care without the worry of oxalates. Thanks for watching. You can start today. Well, and that goes back. Let's circle back to the thing where these patients are said, they're told, hey, just wait a year and see how it goes. And then most of the time it doesn't go so well because the nerve has further trauma or further degeneration to it. Motor end plates are starting to drop out. So I think it's a great disservice to the patients for them to be told this. And that's what's so powerful about this, because it's not a hard test to do. It's very inexpensive. You have to have a little bit of ultrasound experience, but within 5 minutes, you can tell this patient whether they have a good chance at regaining everything or they may have to go into the nerve transfer arena. So it's a very powerful thing. I mean, I think of all of, the nerve blocks that we do, we've been just 99% of the time focusing on how much pain is relieved from this block that we're putting on. But that's even interesting if you think about it, because how many times have you given a peripheral nerve block for pain and you put in a very little amount and they don't have any, their pain goes away, but they don't really have any, they don't have really any noticeable anesthetic effect. Their sensation actually is increased, their muscle strength's increased, but yet they say, oh, my pain is gone. So is that just a phenomenon of the local anesthetic from its anesthetic action, or is it maybe I just got some more blood to this nerve and now it's functioning a little bit better? I don't know the answer to that.
Well, lidocaine is a vasodilator.
Yeah, big time.
So I think that what you're doing is basically providing more blood flow. To that area. So I think that that's really the key point. But I think that the Phoenix sign, like you well explained, it needs to be more popularized, in my opinion. It's still not really. I think that if you ask orthopedic and pediatric traumatology residents, have you heard about this sign for peripheral nerve surgery injuries? They will tell you, I would say, over 80% they have not heard about it. Right. So I think that that's really had to be published more. And that's perhaps the reason why I have been always a big proponent of publishing my articles of peripheral nerve in the Journal of Plastic and Reconstruction, because that has a high audience of surgeons dealing with peripheral nerve.
Right.
Yes, I had done a couple articles of peripheral nerve also in the Journal of Foot and Ankle Surgery, but I have focused more on the plastic journals.
Right. Well, I'm working on trying to get that out. I have been, beating the drum for about 5 years on it. So maybe, 20 years from now, when I'm long gone, somebody will say, oh, this was a pretty good idea.
No, and you know what? I think that this may be a great way to do like a collaborative article with fellows. a great fellows collaborated article in which you can create a table, pre-post injection, and then pre and post muscle strength. It's not really that difficult for study to put together.
No, it's very easy.
Yeah, it's very simple. And then duration, all of them being done by ultrasound guided, all of them with lidocaine plain, same amount of medication. It's a very simple. You just need to have a good number, good 35, 50 cases. But if you do this as a collaborative effort with a centralized IRB, I think it's a great study to publish.
Yeah, we've got a couple of studies in the IRB pipeline right now. We'll talk about this after we get off air, because I'd love to get your insight and maybe have some of your folks participate. So one of the other articles that you published, which I found very interesting, was your reset neurotomy paper.
Isn't that amazing?
Yeah.
That one is it's one of my top procedures right now that I offer my patients. And Dr. Oberlin deserved the credit because the first paper that I read was Kyle Oberlin in PRS. I read his article of reset neurectomy and for the sural nerve. Now I'm performing reset neurectomies of the saphenous, superficial, and sural nerve. So these are in patients that they don't have identifiable neuroma formation.
Right.
They respond very well to a local block.
Right.
They have an area that is a true dermatome neuritic symptoms, and nerve conduction studies are normal. So I think it's basically disconnect the mind, the brainstem, the thalamus from the extremity, and in that way allow some new regeneration with a new signal to the central system.
Explain to the audience what we're talking about from a technique standpoint.
So once you identify the compromised nerve, let's say that is the anterior aspect of the leg, well, perhaps most likely the target nerve will be the superficial peroneal nerve. If it's the medial aspect of the leg into the foot, most likely it's the saphenous. And if it's more posterior to the fibula, distal 1/3 into the lateral aspect of the foot, most likely it's the sural. So then I provide the patient with an echo-guided nerve block. All those blocks, they have to be away from the zone of injury. Right. So these are for patients that have lower limb and foot pathology. So done perhaps 10 to 15 centimeters above the level of the ankle. Just a small, minute amount, maybe 1 cc, 2 cc's of lidocaine, ultrasound guided, and see what is the reaction of the patient. And the patient, they said, wow, doc, it feels fantastic. All the burning pain and tingling and soreness of that area is gone. Then I send them to nerve conduction studies that are negative. There's no compression, no there's any problem with the axons or amplitude. So conduction velocities, and evoked potentials are within normal. So then what are the options that we have? There's not a neuroma, there's not a compressed nerve. So then what do? So then basically we transect the nerve, also known as a neurectomy, and then we place an interpositional graft with 2 conduit at both sides to prevent.
And how long is your allograft usually? Are you using a 7 centimeter?
In those cases, based on Oberlin cases, if you want nerve regeneration, so in the lower extremity, I think that you definitely want to stay within the 3 centimeter gap. Okay. I think more than that, upper extremity, the data is very clear that you can go up to 70 centimeter. But in the lower extremity, from what is being published, doesn't seem to be the case of adequate regeneration for motor fibers in cases that are over 4 centimeters in length. So I try to put a gap of 3 centimeters with a conduit in both sides.
What type of let's talk about sural first. What type of resensitization are you obtaining with that? Is it diminished? Do they have a diminished capacity after you put this in the position of grafting?
In patients that they don't have any pre-existing disorder like diabetes, right. I would say that is full sensation with absence of pain. It's
Wow.
very powerful, very, very powerful.
And even if you're not getting full sensation restored, you probably are still doing well from a pain standpoint.
I always say you restore quality of life. So in the lower extremity compared to the upper extremity, when you eliminate pain from the extremity, you restore life. In the upper extremity, when you eliminate sensation, you create a disability. So it's a complete different, and that's something that I explain to my colleagues all the time, that if the sensation is not restored completely, it's a successful case. The patient can actively move, can sleep at night. As you know very well, a lot of these patients are suicidal. They they cannot sleep at night.
Right.
They cannot wear shoes. Nothing. No one can touch their limbs. So if the sensation doesn't come back, it's not a problem. I tell the patient, if you don't wake up with numbness in your extremity, it's not good news. I want you have numbness. Right. So they're happy when they tell me, hey, doc, there's numbness. So in that way, it's very beneficial for both.
Now, in my mind, the superficial perineal is more difficult to take care of than the sural, just simply because I think it has a bigger brain map, and brain doesn't like it when we take away a lot of that cortical surface activity. What is your experience, sural versus superficial perineal? Saphenous, I would think, would be even better than either of those two because of just its nature.
That's right. So the sural nerve has 8 variations, and the superficial perineal nerve have 4, and the saphenous have 3. So what you've been taught in school of anatomy is not quite what we see on a weekly basis. So I think that ultrasound guided nerve block is mandatory to be identified if the sural is a branch of the common, or it's a branch of the tibial, or it's a combined branch, or 2 separate branches at the distal 1/3. And like you said, the mapping is everything. When it comes to the superficial perineal nerve, it's more predictable than the sural because of that, because the distribution and the mapping of those nerves.
What about saphenous? Is it the easiest one for you to do this?
The saphenous, I just recently did a case from a saphenous patient came from out of town and had multiple neurectomies performed already and ongoing pain. But what was happening on the ultrasound, I noticed that about 5 centimeters above the ankle, the saphenous nerve was split on 3. So the neurectomy was done on a branch, not on the trunk. So then I went about 18 centimeters above the level of the ankle, provide the patient with a nerve block, and the patient said, for the first time, I'm completely pain-free. So that's the target. That's the area where I would do the reset neurectomy.
Right. But I mean, I guess what I'm asking is, from a clinical outcome standpoint, do you see any difference between the saphenous, the superficial perineal, and the sural? Because I feel like, at least in our clinical experience, the superficial perineal has less predictable outcomes because it has such a big innervation pattern versus the sural, which is smaller, and the saphenous is even smaller than the sural in most cases. You know, and of course, there's a lot of anatomy variation.
Yeah, the superficial perineal nerve, even though has less variations than the sural, I think what is happening in some cases, it has some connection with the saphenous medially, and it has some connection with the sural laterally. So, but at the end, if you can reduce the pain level of this patient to 50%, even only 50%, the patient is going to be very happy with you.
Right.
And so even though they may have some symptoms medially or laterally and not just and centrally, they're perfectly fine, they will do overall a lot better. Then I would just schedule them perhaps for a sural neurectomy with a reset if it's the lateral side is still a little bit compromised. And if it's medially, then I will go to the saphenous, provide the patient with a nerve block, and see what happens.
All right. So how are you, like, let's say you have something that's involving both superficial perineal pretty extensively and sural. Are you doing a blind loop still on those folks? Or are you doing these double reset neurotomies?
So if there's an identifiable nerve injury and there is a type 2 nerve injury or neuromin continuity, I will and the zone of injury is an area that it could be reconstructed, I will repair those neuromas. That's where I stand. If it's a non-reconstructable zone of injury, in other words, surgery could compromise that area that I may have a problem with soft tissue envelope, then I would do a loop transfer just proximal to the zone of injury.
Okay. Yeah. And instead of doing the double neurotomy for each one, you would just do a blind loop, right?
Yeah, I would do a neurotomy of both and then connect together. Yes.
Right. Yeah. I think the brain loves it when it can connect to something. You
got it. I think that, and there may be more. I have seen wonderful outcomes with that. I did a case last week that it was a superficial to deep peroneal nerve about 15 centimeters above the ankle for the management of the dorsal crutch type of injury that the patient had. I think the patient had 7 procedures in the dorsal of the foot and ankle.
Right.
So there was no way that I can go into that area. Soft tissue was terrible.
Right.
And I did a transfer of SPN to DPN, but then the sural, I did a reset neurectomy.
Okay.
And the patient, after 11 years, the patient said, for the first time, I think I'm going to have a good night rest. It came from out of town. So I think that seeing how these patients are doing after is the main reason why I want to train more people about it.
Right.
Because at the end of the day, these patients are desperate. And I'm a true believer, based on the same article of PRS, that peripheral nerve surgery is the best way to fight the opioid addiction when it comes to lower extremity chronic pain syndromes.
I would think it'd be pretty hard to disagree with that. And the sad thing is that we can train up a whole another boatload of people, and it's still not enough to take care of all of the peripheral nerve pathology that's out there. It's extraordinary how many people are suffering from a peripheral nerve injury.
Yeah, and I think that's the reason why the American Extremity of Nerve Surgeons is, I'm a big fan of them, in the sense that promoting basically an adequate education. Basically, the diagnosis, I tell my residents and fellows all the time, after a major trauma to lower extremity, if the patient is complaining of symptoms at night when they're not upon any type of weight-bearing forces or biomechanical or range of motion, think about nerve injury right away.
Right.
Don't think about orthopedic problem, think more as a neurological problem.
Right. Well, I think what you're doing with CLES and your training and, the crossover with the Association of Extremity Nerve Surgeons, I think, we are starting to get a lot more people trained, and, awareness then brings implementation. Even if it's not them that are doing it, but they're aware of it, then they can send it to somebody, in a tertiary center and say, yeah, there's something that can be done, for it.
Yeah. And I think that the symposium provided a great platform for continual education, hands-on for surgeons. I'm the first one in the lab dissecting. I'm pulling to my table, hey, what exactly are you doing now? So the collaboration is great, and I'm excited to be in that meeting because I'm actively dissecting for my own knowledge.
Right.
As a consequence of the symposium, I said, well, what else we can do for the traumatologists, orthopedic and pediatric surgeons to continue some collaboration all year round. And that's when I developed and I create the American Orthoplastic and Microsurgical Society.
Right.
It was only doesn't have no interest or approach in any type of credentialing, politics. It's purely educational research and mingling with another society to grow and provide better patient care.
Yeah, no, and education is very powerful, not only for the physicians and surgeons, but also for the patients, because like we said, there's so many people running around with these pathologies that hardly anyone knows, what to do about it. A great example is total knees. I mean, if you look in the literature, I think it's pretty underestimated how many injuries there are to the common perineal after total knees and total hips. Some say it's like 1%, others say it's about 4%. There was a anesthesiologist, pain management specialist from the Hospital of Special Surgery that presented, I think it was a 5 or 7 year retrospective review of, I think it was close to like 30,000 patients. It was a lot. And they found that it could be as many as a third of patients that undergo these procedures will have some, sequela that involves nerve pathologies. That's a lot. And then,
it's a lot, yeah.
Yeah. And I can't tell you how many folks have come to our office and they've had a total knee and they've had chronic pain and they've had multiple imaging. There's nothing loose with the implant. There's no infection. It's perfectly aligned, but yet these patients have pain. And it's a simple nerve, whether it's a small genicular branch or maybe a bigger branch like the common. And all of a sudden you take care of this and their range of motion goes from restricted to full range of motion instantly, and their pain goes away. And it's a simple thing to take care of. But think about 99% of ortho doesn't even recognize that, hey, this nerve could have been injured a little bit. Not that they did anything wrong. It's just nature inherent in the procedure itself. But think about how powerful it is if we can get this knowledge out. I mean, that you could have a whole practice just on that subset of patients.
You got it. And that reminds me of a patient that was scheduled for a high tibial osteotomy to offload the medial compartment of the knee. And she had an appointment to see me the week before the procedure was scheduled because the patient had some neuritic symptoms in the lateral compartment of the leg. So I gave the patient an ultrasound-guided nerve block of the branch from the common to the knee, and the patient's pain completely went away and symptoms went away. It was a week from her going through the procedure. And she called her doctor and said, listen, it's been a week and I had pain on a daily basis. And for a week, I have not had any symptoms. I think I want to put a hold off on the procedure.
Right.
And it is amazing. Still to this day, the patient is, I did some radio frequency of that branch and I solved the problem.
Right.
So I think that there's so many options, and I think that what you're doing with this type of podcast and your initiative on peripheral nerve are awesome. We just need to figure out a way that more people can see it and more people can be aware that we need to be better clinicians when it comes to peripheral nerve.
Yeah, no. And the interesting thing, and I don't know about how your journey was, but you start to get into this and then it's very seductive. And then the next thing you know, and I don't know, did you experience that in your journey?
Extremely, because I started performing peripheral nerve surgery as a result of limb lengthening procedures. So that was the beginning for me. So I started getting involved in limb lengthening procedures, angular correction, pediatric and adult, especially trauma patients with shortening post-tibial fractures, pylon fractures, and talectomies. And in that process of performing the re-lengthening and bone transport, I encountered a lot of nerve injuries. And I'm like, okay, what do I do now? And that's how I end up collaborating with you, Dr. Ivica Dushik, other surgeons in peripheral nerve. Then I went to Hopkins to do some training also there. And is at this point in my career is the most satisfying aspect of what I can offer to my patients.
Yeah, without a doubt. I mean, you made a point about how many of these people are sadly suicidal, and it's probably 15-20% easily. And sometimes it doesn't take much to change that whole life around.
Exactly. And they've been taking massive amounts of drugs and opioids for years and no hope. You see them sometimes that the family nucleus have been completely disrupted. Very sad, very sad. It's what you see with people with peripheral nerve injuries.
No, it is. Well, Edgardo, thank you so much for what you're doing, not only for me coming on the show today, but for the profession. You are really one of the icons and beacons of our profession, in my opinion, and your CLES symposium is really world class. I hope to get over there next year for it, and just thanks so much for what you're doing and helping everybody.
No, thank you for having me. And this is just a great platform for us to continue collaborating, and then perhaps we can have more surgeons coming from all over to the training that we can provide. This year at the symposium, we have physicians, surgeons from Bolivia, Venezuela, Colombia, Chile,
wow.
Mexico. We have some doctors from Italy, Europe, Spain, and of course the U.S. surgeons. And I think that the concept is to spread out more knowledge and have the surgeon not in just one event or one day, in multiple days, 3, now 2, now 3 days, that they can practice the same skills. So when they go back, they feel secure that they can perform these procedures.
Right. Well, this stuff is so complex, not only intraoperatively, but for making the right diagnosis and figuring out what to do, because they don't fit in algorithms. Every one of these patients is really an individual patient. So it really takes a lot of acumen to figure out what is the right approach. And that's why you're publishing these articles is so important, because it gives us an ability to look at these things like, oh yeah, I could do this maybe, or a combination of this, and maybe increase my outcomes. So
yeah, no, I think that we just need to continue forward. That's a path. I think that we still have, you and me, a couple more years that we can educate and motivate people to start looking a little bit more than just orthopedic,
right.
orthopedic care.
I agree.
Yeah.
Edgardo, thank you so much. I hope we can cross paths in the near future, and I always get energized when I hang out with you.
Fantastic. Well, listen, we're going to make it happen then in the 2024. Have a beautiful day.
You too. Bye-bye. This episode is sponsored by Zuckerman Future Technologies. Their REMI laser is a Class 4 laser for professionals. It's different from anything available on the market in that it is a lightweight, 4 pounds, and compact but powerful device. Its large touchscreen makes it easy to use, and the multiple wavelengths, 650, 810, and 980 nanometers, power variables up to 30 watts, and a safety rating make it optimal for many conditions, including the effective and pain-free treatment of soft tissue issues such as plantar fasciitis and Achilles tendinopathy, peripheral neuropathy, neuromas, arthritis, onychomycosis, warts, and more. It is the only laser with FDA 510(k) approval and insurance coverage. Zuckerman Future Technologies was built to focus on quality products and excellent customer support. When you join the REMI family, you will receive one-on-one training and ongoing support. Zuckerman Future Technologies deals with all aspects of the REMI in-house, and this keeps out the middleman, which allows them to offer this revolutionary device at a 40% reduced price compared to anything that can provide the same or similar results. In addition to this, Zuckerman Future Technologies provide a comprehensive, well-rounded marketing platform that includes customizable brochures and posters, in-office educational videos for your patients, as well as web page and hard copy ad templates. There are currently over 700 REMI users in the United States and Europe, and those numbers are rising every day. Learn more about this fantastic product and join the growing number of professionals who are benefiting from having the REMI in their practice. I personally implemented the REMI laser into our practice about 4 years ago, and I cannot say enough about the utility, versatility, and efficacy that I have seen with this technology. I also can say that of all of the capital equipment that I have purchased, and trust me, it's been a lot over the last 36 years, this is one of the best expenditures I have made. Zuckerman Future Technologies is offering the listeners of the Pod of Inquiry a really great deal. You'll get a $1,000 cart for the Remy laser when you use code 007. That's right, a $1,000 Remy laser cart for just the bona fide Pod of Inquiry spelunkers. You can go to the website, remylaser.com, and use the code 007.
We hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes, found at our website, podofinquiry.com. If this incredible and educational conversation has tickled just a little bit of your cortex, please leave us a review and spread the message to your friends and colleagues. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show, if used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.